So welcome everybody. Good to see people here on the call. You're probably wondering why I'm wearing a strange hat with a television on the front. I haven't lost my marbles completely. The reason that I'm wearing a purple hat is it's Pancreatic Cancer Awareness Month. Purple is the colour of pancreatic cancer, and each day in November I wear a different purple hat on Zoom and Teams calls, so I can tell people that it's Pancreatic Cancer Awareness Month. I can give them a few statistics about the disease. And the reason that this hat has a television on the front is because I kind of took the inspiration from children making Easter bonnets, and I thought I would make myself a hat for World Pancreatic Cancer Day, which is today. So it's got lots of things on that mean something personal to me, because sadly my husband died of pancreatic cancer 10 years ago. Pancreatic cancer is at the bottom of the list of cancers that have good survival rates. Nothing has really changed in 50 years. 1 in 4 people sadly die within a month of diagnosis. 3 in 4 people die within a year. And for every 10 diagnosed, 1 gets the chance of life-saving surgery, 2 get chemo, and the remaining 7 get no treatment whatsoever. So that's the reason for wearing the purple hat today, because it is World Pancreatic Cancer Day. So I just wanted to share those statistics with you as an aside, but please try and ignore the fact that I'm wearing this hat and don't let it take away from the serious messages that I'm going to give you about storytelling as we go. So today we're going to look at storytelling, particularly digital stories. What are they? How can we use them? How can they influence national policy? And I'm really pleased to have with me today Vicky Drummond, who was an ex-colleague who shared a story that had an influence on national policy. Vicky, do you want to say hello to everyone?
Hello, everybody. I'm Vicky Drummond. I'm glad to join you today.
Yeah, we'll hear much more from Vicky a little bit later as we go along, and how Vicky shared a story and what changed as a result. So completely unfamiliar with Zoom, so I'm just going to try and share my screen and make sure that I put on the sound. And you're going to tell me if you can see what I'm sharing, because I've done that before, haven't I? Can you see that, Jorian?
We can see the presentation.
Very good.
But yeah, last time we had a problem when you tried to press the present full screen mode. Do you see it full screen? Because we don't.
I can see full screen currently. You can't.
We see the current slide, but also the other ones. Lesley, try to press the button share, the green one, and then there's a button with the entire screen. This is the one that is the least problematic of all the buttons.
Thank you. Entire screen, okay. You've just got me now, haven't you?
Yeah, we see you. But now when you swap to the presentation, we should see exactly what you see.
How's that?
No? I see your mouse on top of the button from beginning, but you haven't clicked. Yes, that works. Perfect. 10 out of 10.
Wonderful. Excellent. So today we're going to talk about stories and the impact of storytelling in health. And we're going to explore how personal stories can impact national policy. So just a little bit of background. We're going to particularly focus on digital stories today. So digital stories in healthcare are essential for fostering empathy, communication, enhancing learning. Stories bridge the gap between sort of medical knowledge and human experiences. They make that connection and can ultimately lead to better patient care and informed decision making. And often digital storytelling particularly can provide that emotional scaffolding, that safe place for people to learn from other people's personal experiences of healthcare. So emotional scaffolding is a term that's often used in education to denote a safe place to learn. So stories and storytelling are about human connection. When we share personal stories with others, we invite them into our world and we create a sense of intimacy. By sharing our experiences, vulnerabilities, and triumphs, we deepen the relationships that we have. And healthcare often includes life's pivotal moments, which include things like the sacred moments between birth and death. So it's applicable, all those moments. Most people through their lifetime go through the health and social care system and have moments which are really sacred and important to them. And sharing those in a safe way through storytelling creates that communal currency of humanity. One of the most compelling aspects of storytelling is the ability to convey authenticity. So when we share our own experiences and perspectives and truths, we invite people to connect at a deeper level. And by embracing authenticity and being vulnerable, you can create a genuine connection with an audience and leave a lasting impression that resonates. So storytelling reveals meaning without committing the error of defining it, because it means something different usually to different people based on their own authenticity and vulnerability. So digital stories, what are they? Why are they important? So digital stories are first-person stories told by a patient, a carer, or a member of staff in their own voice. They're usually between 3 and 5 minutes long. They're audio recorded, edited in partnership with the storyteller, so it's a kind of co-production process. And then that audio is overlaid with art or photographs. Normally, the person telling the story doesn't appear like as a recording, like a video recording. You hear the voice, and sometimes people will put in personal photographs too. The storyteller owns the story, so it's their story, it belongs to them, and they are working with an organisation, a trust, a hospital, or a national organisation to share the story, and they give consent for that organisation to share it. There are usually 3 levels of consent. One is that it's for a specific meeting or a conference. 2 is for educational purposes, but couldn't be shared online. Or it might be that it can be shared online anywhere at all, and people make that choice. So through some work that I did in NHS England, we trained over 150 people in providers and cancer alliances how to do digital stories, the skills that they needed to be able to do them. And we also developed an impact and outcomes framework. So we're going to go back to some work that I did a little while ago at NHS England. So there are 2 different models of digital storytelling. The first one is the California model, developed in the 1990s as part of a community development arts initiative developed by the Story Center in California. In that Californian method, people share their stories through a story, can't say it, through a story circle, and ask people to give them feedback on the story that they've told. And then they write a short script, they record it, and then it's overlaid with art or photographs. So it's a kind of sharing stories, having input, having a written script, recording that, and then overlaying that with art or photographs. The Swansea model, which is the model that we tended to use in the work at NHS England, the person does an audio recording. They tell the story in their own way. The story belongs to the person and they own it. And then collectively with the storyteller and the story maker edit the audio together, overlay it with photographs. So it's a co-production process. So it's not pre-scripted and pre-recorded. The person, you help them sort of find the arc of the story. What is it that they want to tell? What is it that they want to change, essentially? And then they tell their story in their own way. They're not doing it from a script, they're just talking to you. So what happens with those stories is often what someone says at the end of the recording might end up at the beginning of the story. What's in the middle might end up at the end, and what's been at the beginning might end up in the middle. So it's It's sort of splicing and dicing the story together so that it has the biggest impact, but it is a co-production way of doing it. So up until 6 months ago, I was experienced of care lead in the national clinical programmes, and previous to that for provider improvement at NHS England. And we would take stories to the National Quality Board, which had chief nurse, chief nursing officer, all the chief officers from NHS England, chaired by one of the non-exec directors. Previously, it was chaired by Lord Darcy. And those, we would take digital stories to that board as part of their review of quality. So hopefully the sound is going to work. I'm going to share a tiny little extract from a story that we took there. It's called Sophie's Legacy. It's about this little girl here that you can see called Sophie, who sadly was diagnosed with a rare sarcoma aged 9, had some treatment operations, but sadly the sarcoma came back. And you're going to hear Charlotte and Mum, who you can see there, talking about Sophie writing a bucket list and wanting to do certain things. And Sophie did write a bucket list. She did lots of things. She delivered ice cream to her friends in an ice cream van. She also cooked with Gordon Ramsay because she loved to cook, and apparently he did swear at her too. But there were 3 things that Sophie didn't like when she was in hospital. She hated the food. Her mum was never fed, so because Sophie wouldn't eat the food, Charlotte and Mum would eat Sophie's food because there was nothing for her to eat. And she wanted to have play specialists 7 days a week, because what happened was she would get treatment during the week. On the weekends when she was free to play, there were no play specialists. And in the week when she was having treatment, she couldn't play with them. So if you can just let me know that you can hear this, because I can't see anybody at all. And it should be coming up.
She wrote her bucket list, which included some amazing experiences that you would as a 9-year-old. She knew she was dying. We did tell her that. So she knew that writing some of these things on might not achieve in her lifetime that was left, but she wanted to make sure that I achieved them for her. And the 3 were play specialists 7 days a week in all hospitals. She wanted better food for children, and she wanted parents to be fed. And I think to write that on a bucket list, knowing you're dying, I think at any age, just shows how much that meant to her, and how much that actually needs to change. These weren't things that were going to make a difference to her. They wouldn't help her. She wrote her.
So a little clip from Sophie's story. That story went to the National Quality Board, and we were able to, at NHS England, do 3 pieces of national policy work from that little story. So a whole load of work has been done around feeding parents when they're in hospital with the children, improving food for children when in hospital, and a whole load of play standards for play specialists around being available 7 days a week. So what we were also able to do, working with those trusts that we had trained on storytelling methods, we were able to develop this little impact framework around where the story had gone. So Sophie's legacy story went to 6 board meetings and 5 conferences. Feedback-wise, we got 180 individual feedback messages around the impact of Sophie's story. There were 12 actions. Amplification, we had 700 plus people see the story at the various board meetings and conferences. There was 1,000+ views on the website of the story, and Charlotte, Sophie's mum, also shared it on Facebook. There were 18,000 views of it on Facebook because Charlotte had been blogging about Sophie's experience. It improved the awareness of issues for children and parents when in hospital, and the biggest impact was these 3 programmes of national work then started as a result of Sophie's story. So what we were also able to do was go back to the under 16 cancer patient experience survey that has all the quantitative data in there, and look at the questions around place specialists and food. We were able to triangulate that quantitative data with the free text comments that also came from this survey, and then we were able to overlay that with Sophie's individual story. So we were able to create that link between the quantitative data, the qualitative data, and the narrative in the story. So through that work, lots of this work has now come to fruition through Sophie's Legacy, and you can look up on the kind of website some of the things that have happened as a result, and NHS England working with Sophie's Legacy to launch that initiative to feed parents in hospital. So Sophie's story really brought together that idea of quantitative data, which is numerical, measurement, factual, along with qualitative data in terms of that free text comments, and having stories be the bridge between the two. And I always kind of think of it as a kaleidoscope. When I was a child, you look through a kaleidoscope, you move the end, and if you looked at the data through the lens of quantitative data, you would have a different picture. Through qualitative data, you would have a different picture. And through narrative data, you would have a different picture. But actually, if you brought those together along with looking at patient, staff, and carer information, you would bring together that full picture. So that's Sophie's story. I'm going to introduce you to Vicky's plea. You've seen Vicky at the start there, and we're going to talk to Vicky shortly. But Vicky shared her personal experience of healthcare, and we took Vicky's plea, the story, to the National Quality Board, and from that story came some national work around something called Partners in Care, Care Partners, and prompted a whole raft of national work around when people go to hospital, whether it's for an outpatient's appointment, whether it's an inpatient stay, whether it's an emergency admission, or if they go to the dentist or the opticians or the GPs, and they feel nervous and they need someone to be there with them any time of the day or night in a hospital setting, that they could nominate a partner in care who could be with them. And Vicky's plea is a very, very personal story, and Vicky will talk more about that, which prompted this discussion around having care partners and prompted a whole raft of work that is still underway. So we're going to watch a little bit of an update film and also just go through the impact of Vicky's plea story. So Vicky's plea went to 1 board meeting and 5 conferences, again 143 messages of feedback around the impact. There were 7 actions that came out of that. Over 2,000 people across those board meeting and conferences saw Vicky's plea. It recognised, helped to highlight the value of having the person who's important to you with you, and that visiting is often seen as something different to having the person who means the most to you there when you need them. And the impact was the review of the guidance and the development of the care partner policy. So a little bit of feedback from Vicky's plea. It really hits home. I have seen similar practice that I would really challenge staff to say it's better without visitors. So Vicky was admitted to hospital as an emergency through the emergency department during COVID, during the lockdown, feeling really quite unwell, and was admitted, couldn't have a husband or a family with her because of the restrictions. Underwent a number of investigations, and then by the Monday was expecting some scan results, which were given to her when she was alone, when her husband had asked to be there with her, and when he was actually sitting on the car park. So just in terms of the care partners principles, so the work that was done out of the back of Vicky's plea was around compassionate care, making sure that we shared knowledge and experience, working on the principles of co-design and co-production, collective action, doing this across a whole system, and embedding person-centered care. So the story that I'm going to share with you now is it isn't the original story, but it's an update from Vicky on the original story and the work that's done and what it meant to Vicky that somebody listened to her story, understood her vulnerability, and then did something to change things.
Everybody needs a care partner. Everyone needs that choice. I really believe that if we limit care partners to those with a recognised carer's role or those who identify as a carer, it's a different thing. And many individuals, such as myself, who for whatever reason would like to be or need to be supported by a specific person along their journey, might miss out still. And that's really important in supporting them to be able to receive the physical or emotional support whenever they need it. I'm conscious that in certain circumstances, and for some individuals, we have really good arrangements, quite rightly, in place to make sure that people are supported. But I really, really believe everyone should have this choice to be supported by a care partner. And I really hope that we can really make it something that is in place for absolutely every individual across our system. I'm Vicky, and I'm sharing my experience as a patient in relation to hospital visiting restrictions today with you. And I'm going to apologise in advance for coughing and breathlessness because I'm struggling at the moment with both of those symptoms. So I'm a mum of two gorgeous boys and very fortunate to have an absolutely lovely husband as well. And I'm privileged to have been a nurse for the last 30 years, which I'm very passionate about. Unfortunately, I became acutely unwell at the end of July this year. Monday morning came and still on the coronary care unit. And my husband was so concerned, he'd driven down from our house and he was parked in the hospital car park. Still unable to come in, but he'd rung the unit and said, if there's any news at all, I have to be there with my wife. And it assured him that, the doctors would be around and, everything will be fine. Which of course it wasn't. The doctors came round and they didn't give me the CT results, but they started to talk about transferring me to an oncology ward, which is for cancer care. I started to freak, if I'm honest, because I was saying I don't have cancer, there's no sign of cancer. And I don't know why you're transferring me to oncology. And the sister was very kind and moved me into a side room. I was deeply, deeply distressed and said I wanted my husband and she said, well, where is he? So he's parked in the car park. I feel very glad when I see the enormous amounts of effort, drive, commitment taken by individuals, teams and organisations in relation to care partners. And I think for me, what what's really important on a selfish level is it's given me an absolutely huge sense of comfort and reassurance that individuals can be listened to, valued, and their insight acted upon. Because I think that's something I really struggled with when I shared my story initially. Apart from feeling that I had no control, I also didn't feel listened to or valued as an individual at that time, because it was the big system processes that were keeping me apart from my loved one when I really, really, really needed him. I felt in spades this sense of comfort though and reassurance because of some of the work that I've been privileged to see taking place in relation to care partners in Barnsley, looking at what they've been doing in Lincolnshire. Well, it's really difficult to describe how vulnerable I felt, and I still do feel vulnerable sharing my experience and asking for help and advocating for patients. That's been really heavily outweighed by seeing the care and compassion and drive to improve support for not only what matters to me as an individual, but also who matters to me, ensuring that processes are in place which support those identified, which for me was key for my husband to be an active care partner. I've absolutely loved hearing about developments taking place, in part through my experience and that of others who've shared their stories. But hearing about what's taking place in response makes a massive difference when you've shared your story. I can't imagine what it would be like to have exposed my vulnerabilities through recording a story and to hear nothing back or see no action. And I think for me, that's really emphasised the absolute importance of providing feedback to those who really generously and often bravely share their experience. I know that I'm very fortunate in that I had existing relationships with outstanding colleagues who've contributed massively to driving this work forward, such as you, Lesley, and Jackie Murphy. And I also had a wealth of experience as a nurse and navigating the system. And I think that's led me to reflect on how we can improve accessibility and support for individuals to share their experience and shape improvements in care who don't have those relationships, especially when we consider those who we often already don't reach. I think that's really important to consider going forward, focusing on what's important to individuals like me and also who's important to them as their care partner is really central to person-centred care, and the benefits of embracing care partners through things such as broadening visiting arrangements, welcoming, valuing carers' involvement has been really evident in the feedback. And I think that going forward, it's really crucial though that we remember care partners need to be a supported option for absolutely every patient, not only those who have unpaid carer roles or specific circumstances. I'd really, really, really love to see individuals being able to choose to be supported by someone of their choice, their care partner, on many occasions, across all areas of the system, really, so that it's really clear that this is something that's important to individuals, to part of their choice, because the benefits to both patients and colleagues are evident, and I just think they'll continue to grow as care partners expand across the system. These things don't cost resource. These things you don't need to put an extra person in to improve the experience of care. It's how you deliver what you're already doing or should be doing or are trying to do. We don't need extra money. We don't need extra nurses. We don't need extra team members. We need people to listen and respect and value that person they're working with. It's that, isn't it? That's what we need.
That you hear and plead to do everything possible to advocate for patients. Really try and put yourself in their shoes for a few minutes and listen to what matters most to them, and really challenge yourself to think about how you can help them to get through the day. Perhaps the one thing that matters most to them.
So I'm going to stop sharing hopefully. And I'm going to come back to you wherever you are. Have you got me back? And Vicky, are you there? And do you want to say something around? That must have been really difficult to sit through that and listen to it again.
It is. It's really hard. It's really hard to watch back, and to listen to your own voice and the horror of it all. Really, I am still really fortunate, as in, my prognosis was really, really poor, and I'm still here. And as Lesley included in one of those last slides, I've been really well supported. Losing my nurse registration was a big thing to me, and I didn't want that to happen, but I wasn't well enough to have a full-time role anymore. So my local trust has employed me on a really flexible basis. So I work on the staff bank, working around experience, person-centred care and involvement. And that's allowed me to do enough hours to keep my registration and to still feel like I'm contributing and making a difference. It's also really helped me to build on this work that Lesley was doing and in which I took part in. So some of the things that I've been doing is I commissioned digital storytelling training for the trust. And so at the trust, we didn't have anybody doing it, and we've now got 7 trained facilitators. We also started a new work strand on person-centred care, and we've recorded a film on what matters most to people, what it means, and that included working with patients, carers, staff members, and co-producing a really lovely, easy to see 3-minute film that highlights the importance of person-centred care and the difference it makes to individuals. And in a nutshell, it was focused on what's important to them, and us as professionals listening to that and then helping them to achieve that, whether it was having a shower, whether it was going home, whether it was having somebody to come in and visit them. So I'm really pleased. I'm really pleased that the work's going on, and I think the impact of stories has been phenomenal, really. When I went back to the trust first and people were sharing stories, really, it was quite often people reading almost like a case study in a safety quality board or at trust level. The difference when you hear or see the person who's sharing their story and you get to hear about it in their own words is hugely impactful. And I think it really hits home and it stays with people. You can almost still see in your mind and hear that voice, and it really is motivating people at my local trust to embrace stories and to make changes. So yeah, that's what we've been doing since completing the stories and the update locally.
Brilliant. Thanks, Vicky. And if I could give you a hug, I would, but I can't through a screen. Because you're just amazing to have taken on that mantle and to have done that work and be so committed to it.
Thank you.
So happy to open up the conversation, because it'd be really good if people had got questions if they've got any questions they want to ask, or any comments or anything they want to talk about. I'm sure Vicky would be happy to contribute to that too, but it'd be great to hear from you. And the film that we just shared was a little bit of the original film, some little clips, and you would hear the vulnerability in Vicky's voice, because that was quite soon after that diagnosis, and you were really, really poorly at that time, but you so wanted to record that story, didn't you? And then you can hear the difference in Vicky's voice when she's talking about the work and Vicky now. But the vulnerability at that point in time was really sort of part of the emotional scaffolding, the learning, the connection, that authenticity, just feeling that pain that Vicky felt not having a husband with her when he was sitting on the car park. So anybody got any thoughts, questions, anything they want to say?
Just a tiny bit of housekeeping. First of all, the question that I know somebody's going to ask. Yes, we'll share everything with you. If you sign up for the email, yeah, I'm going to get all the links, all the videos with Lesley and everything, and you get that in your email inbox, so you don't have to worry about that. This includes the recording for today. And if you want to add a comment, ask a question, please do so. But I'll ask you to you hover your mouse on the bottom of the screen. You will see the React button. And one of the options when you click this button is called Raised Hand. Please do use the Raise Hand function, and we'll go one by one. And please do share. The whole point of us organizing those calls here is to create this community. So it's not like talking at you, but to create a space where we can all talk together.
I hope we've still got some people out there who haven't dropped off or are sobbing up the corner somewhere. We don't want that. We want them to talk to us. Because both of those stories were really, really impactful. And Sophie's legacy is much longer than five minutes long. It's about 12. But it is out there. So Charlotte Sophie's mum wanted it to be shared anywhere, including on the web. So if anybody wants to watch the whole of Sophie's legacy, and in that story you can hear Charlotte talk about Sophie and what happened, and obviously it's a very sad, monotone voice, but we kept recording afterwards, and then Charlotte started to talk about what Sophie was like as a person, and when she met Gordon Ramsay, and the fact that he'd sworn at her. And you could just hear the joy in her voice because she was talking about the little girl that she loved, and it was really marked. So we kept that in the film and made it much longer. And then we included a little bit of Sophie talking too, so that people could really understand. And it broke the rules of digital storytelling, but for a good reason.
Lesley, I was wondering whether people have had any challenges in getting digital storytelling off the ground in their own areas of work at all, or if anybody had any questions around that.
Yeah, that's a good question, Vicky. There are definitely challenges to be had. So Linda's asking, what tools did you use to record the audio and videos? On the I think on Vicky's plea, we did it through a telephone next to a computer speaker, because that was the only way we could get hold of Vicky. But usually it's just a Zoom meeting or a team meeting like this recorded, and then through some of the video editing programs you can take away the person. That isn't what I mean. You can take away the visual representation of the person and just leave the audio, and then start to get the photographs that represent the story. And you just need to make sure whatever photographs you use, there's no copyright issues, that you're using copyright-free pictures. And particularly when you're working with people, in Vicky's story, she shared lovely pictures of her sons and her husband. Just double checking that you've got the permission of the people, that they do own the photographs and they're not sharing pictures of people who perhaps wouldn't want to be in there. But if anybody wants more details, we can share the kind of sign off, governance, consent forms, those kind of things around it. But it's really important as a principle that the story belongs to the person, not to the organisation, and that the organisation gets the permission from that person to share it. So Vicky's permission to NHS England was that the story and the update story could be used for education, but that it would never go on the web. So the recording of today's story, please make sure that you don't kind of tweet that out anywhere, because Vicky wouldn't want her sons to see that story necessarily, but wants to share it to help people understand. Hope that helps from whoever asked the question. Yeah, Canva's good as well, but there's loads of applications out there that you can use. Some now with AI make it much easier to edit the audio, because it takes, if you've got, Vicky didn't and ah, but if you record a story with someone who does lots of ums and ahs, it can really detract from the video because you start to hear just all the ums and ahs. So when you're doing the editing, you get to see what it looks like, and you can go in and edit them out because you know exactly what that person's audio looks like or ah. But it takes quite a while to do that sometimes. Yeah, and Jorium does the digital store, the podcasts and videos. Yeah, great. And Vicky, thinking about the question that you asked about challenges, I suppose my experience of doing digital stories is often it's quite difficult for and forgive me if you're a comms person on this call, if you work in communications, particularly in a trust, you tend to want to do stories where you bring someone in, put them in front of a white screen, stick the logo behind them, point a camera in the face and say, tell me your story. And then what tends to happen is the person tells the story that the trust wants to hear, because having a camera shoved in your face with the logo behind you can sometimes be a bit intimidating. This gentler way of doing stories allows people to own the story, do the story in their own way, and they own it, and they give permission to the trust to, or the organisation, whatever it may be, to share it. So I've found often that comms people like shiny logoed, polished videos, and don't like audio, like Vicky's audio, where it was quite quiet because we did it through a telephone when it suited Vicky when she wanted to tell her story. And I don't know whether you've had the same thing in the work that you've been doing, Vicky.
I think in our local trust that the difficulty has been that the comms team weren't resourced to do work around improving experience and insight, and so their focus is very much on outward facing comms, and whilst everybody in the trust was signed up to using insight for improvement and improving the experience, there just wasn't a resource there for them to be able to do it. Because our comms team have the expertise in recording things and providing, really good quality outward facing comms, they had a real nervousness about clinicians, different staff groups going out and recording stories, and it almost felt like we'd be opening a floodgate of substandard products which would then be branded with the trust, and so that was their anxiety around it, was how could we keep the sort of quality that they were looking for, which wasn't really the most important thing that we were looking for. We were looking for the authenticity. We were looking for making the improvement. We were looking to listen to people and use that to harness that change. I think it's probably took most of the year for us to reach a point where we're all on the same page and that we're comfortable and we've got our governance arrangements, we've got everything in place, we're supportive of each other in terms of different teams, the comms team, the story facilitators, to be able to work really well now together on this. And I think it has been a learning curve. It's been a changing culture really across the trust, embodying and embracing this.
Yeah, and Jane is asking a question around were the challenges initially in seeing tangible actions and decision making following the sharing of a story. Don't know whether you've got anything around that yet, Vicky, because I know you're at the start of your journey.
Yeah, we're at the start. So our training took place at the end of May for our facilitators. So we've got probably a handful of stories which are finished now, which are being used for change. I would say the most challenging thing is for people to be freed up to record the stories, edit them, and finish them, not in terms of the actions. So for instance, one that we've recorded has been in paediatrics, and it's been around trying to improve children's fears of coming when they've got asthma to hospital and the treatment that they might receive. And we've got a really, really lovely family who worked with us, with a gorgeous girl called Lola, who was happy to share her story. And we use that on our sort of preceptorship inductions with all staff members, partly around stories, but partly about change. So that was really quick. We were able to see changes from that straight away, as in people were able to listen, they were able to appreciate how people needed to speak with children, how giving this information and using the film in advance would be really helpful. It'd allay some of the fears. But the other ones, I think it's a slower process, really. It's more time consuming than I would like. You're so enthusiastic, and you can see what you want to achieve, but it's difficult to move at pace and do it really well sometimes.
Yeah. And I think that the challenge is in tangible actions. I think there's something about, finding the people who can support you in, if you're going to embark on doing some storytelling, whether it's digital stories or others, it's finding those people in the organisation who can support you. And it isn't about hierarchy, it's just about kind of influence. We at NHS England, we were really lucky that Ruth May, the previous CNO who retired earlier this year, was really on board with stories, and having that leadership at that level in the quality board made a difference around what we were able to do, and what we were able to take forward. I suppose another thing just to think about is sometimes when a story's shared, particularly with a hospital trust or a health organisation or social care organisation, the people who hear it want to do what they want to do with it, if that makes sense. So they want to go and improve something, or quite often when stories went to board, the people would want to check whether a serious untoward incident had been recorded, what had happened, what was the process. And quite often the person sharing the story didn't even want to say which hospital it had happened in. So there was this kind of jar against what the system wanted to make sure happened, and actually what the person wanted as the improvement. And it was really important working with the person to kind of shape the story around what they wanted to change, if that makes sense. Because the system always wants to, the nebulous system just wants to fix what's wrong, and it might not be what the person wants. And that is often quite difficult. Just checking if we've got anything else. It's all right, I've got a laptop here and no mouse, so I keep going to grab a mouse that's to a different laptop and then realising it doesn't work. Have I missed anything else? So
I think there's one around the calendar of events, Lesley, storytelling linked to themes or the calendar of events, and how do we communicate with storytellers? You're changing campaigns and the story cycle is closed, so to speak.
yeah, that's quite difficult. And again, based on the stories, yeah, there's something about keeping in contact with the storyteller, not kind of just using the story to share, but like with Vicky, kept her up to date with what was happening with care partners. Vicky was involved in sort of seeing the work come to life, understanding what happened in various places where it was tested. But I think finding, I suppose it depends what you want to use stories for, whether you want it to be part of a campaign, whether you want to find a particular theme. And sometimes digital stories are not the right kind of stories for those campaigns. and digital stories are not the only way of doing things, and hopefully as we move into next year we'll explore some of the other ways of telling stories in terms of things like performance, using kind of fables and wonder tales and fairy tales to tell experiences of care, thinking about poetry. So there's no one sort of silver bullet that is the right way. It's a combination of all of those. And the comm stories where people do talk to camera and tell their experience of care, that is the right thing. Sometimes it's using the right thing out of the toolbox for the right things. So I hope that helps, Sarah. I don't know whether I did answer your question, but if I didn't, please shout up. Oh, somebody said something about disingenuous and then it moved. Yes, absolutely, about overuse and disingenuous and manipulative, and that's why, particularly with digital stories, the story belongs to the person. They give consent, they own the story, they get a copy of their own story too, with no logos or anything on. So dependent what they want to do with it, put it on a website or share it with the media or the press, it's theirs to do. But there is something about really working in partnership and co-production with people. Do's and don'ts of effective storytelling anywhere. I don't think we've got anything off the shelf, but I could certainly start to pull something together, and maybe we could in the new year sort of think about we did talk about having more of a discussion and bringing people into the discussion around some of the ethics. Quite often people call stories trauma porn, which is a term that just sounds terrible, but having somebody constantly retelling their story and the trauma that can have on someone, and that's why digital stories are kind of a moment in time and can be shared again and again and again as long as the person wants to. But sometimes, dependent on the condition, particularly in health, people might decide that actually that was 2 years ago and life is now very different to that experience, and may not want that to be shared. So that's why the consent levels are really important. That's a bit about it as well, Karen. Shelf life. Yeah, I suppose it depends on the person. I shared a personal story of mine around the death of my husband 10 years ago and continue to do so, but not in the same way, more in the way that having shared that story influenced me to kind of pick up storytelling as a way of helping others to improve things. But I think that depends on the person who's telling it, and again, that's about keeping that relationship, getting the right level of consent, and tending not to advise people to share things on the internet, because once it's there, and you can take it down from websites, but there's always a digital imprint somewhere. So my advice on digital stories would be to kind of keep the consent and control with the person whose story it is, and then if they decide they don't want it to be out there anymore, it can be withdrawn and there's no digital footprint. So Vicky, any words of wisdom right at the end from you?
Gosh, I don't think so. I think some of the questions around using stories well rather than just as a tick box perhaps is important to get that balance right. There's such enthusiasm in the trust because people want to do the stories. There is an element of creep where people are thinking, oh yeah, we'll do a story, and it'll cover it. And I suppose that's my learning at the moment, is to sort of keep it focused, and keep it authentic to what we set out to do with digital stories, rather than have it as a fix-all for any sort of issues that are flagging within the trust at the moment. yeah, that's my little bit of learning for now and focus.
Thanks, Vicky. And thank you everyone for being here today, for all the questions. You'll get the materials. Vicky, huge thank you, number one, for sharing your story in the first place. Number two, for keeping up to date with the care partner work. And number three, for doing all the work that you've done and being here today. And if I could give you a hug, I would, but I can't. But I will do at some point in time. Thank you, everyone.